This conference will now be recorded.
Hello, everyone. My name is Caitlin Bay-Vislasky, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm pleased to welcome you all to our educational webinar today, hosted by Lymphoma Canada at our national conference on diffuse large B-cell lymphoma. We appreciate those of you able to join us live today to learn more about the disease-specific biology of DLBCL. We will examine the current Canadian treatment options available and will further highlight treatments coming to Canada, as well as the research and results behind new therapies and clinical trials. Before I introduce today's speaker, I would like to provide a bit of guidance about the Zoom software. This virtual software does not allow for you to share your video or microphone. If you do have a question, however, please save it for the non-Hodgkin lymphoma Q&A session following this breakout presentation. You can then ask your questions to presenters live. I would now like to introduce and welcome our speaker, Dr. Pamela Skrabek. Dr. Skrabek is a hematologist with Cancer Care Manitoba and an assistant professor of internal medicine at the Max Rady College of Medicine. Dr. Skrabek's research contributions are focused in non-Hodgkin lymphomas with a combination of epidemiological and translational research projects. As a lead of the lymphoproliferative disease site group, part of her role is to oversee clinical research activities and collaborate in clinical trials provincially and nationally. We thank you very much for joining us today to speak on this lymphoma subtype. I would now like to turn over the presentation to you. Thank you very much.
Thank you, Caitlin, and hello, everybody. Thanks for joining with this national webinar. And I'm going to spend some time over the next approximately 60 minutes talking about diffuse large B-cell lymphoma. We're going to briefly review the characteristics of diffuse large B-cell lymphoma, and this is often abbreviated as DLBCL, and so you'll hear me refer to this specific lymphoma subtype as DLBCL throughout the presentation. I want to talk a little bit about how we make the diagnosis and some of the investigations that go into that. Talk about staging tests and their role, as well as initial therapy at present in Canada as well as worldwide, and treatment at time of relapse. We will briefly discuss throughout the presentation challenges and unmet needs. So as an introduction, about 10,400 patients in Canada are diagnosed with non-Hodgkin lymphoma as of the year 2020 every year. And 30% of these new diagnoses are diffuse large B-cell lymphoma. This is the most common subtype of lymphoma. Diffuse large B-cell lymphoma has a very wide range of symptoms and finding at time of diagnosis. And similarly, it has a very wide range of outcomes. We can see people with very low risk disease that have a very high probability of cure, as well as those with high risk disease with a much lower probability of cure. When we look at people that live in Canada, we see that their lifetime probability of non-Hodgkin lymphoma is approximately 2%, a little bit higher for men. And that's also true in diffuse large B-cell lymphoma overall, that it is more common in men. If people with a first-degree relative with non-Hodgkin lymphoma have a slightly higher risk of developing the same diagnosis. There's many described risk factors for non-Hodgkin lymphoma and diffuse large B-cell lymphoma, but very few greatly increase that risk. The ones that do greatly increase risk are primary immune disorders or other disorders of the immune system, such as autoimmune disease, having had an organ transplant like kidney transplant, having a diagnosis of HIV, or being on medications that modulate the immune system. Just a little bit more information about diffuse large B-cell lymphoma. The median age is approximately 70, but this truly is a lymphoma that we see in all age groups. And so fairly commonly see in the young adult patient population. My practice goes to as young as age 17. but also affects the very elderly patients. It's very uncommon to have truly localized diffuse large B-cell lymphoma. So this is a lymphoma that generally presents with advanced stage disease, stage 3 or 4. The symptoms that patients come in with can be quite variable. So most commonly they present with enlarging lymph nodes. It can be quite rapidly enlarging. Where those lymph nodes are really dictate what the patient's symptoms are. Lymph nodes that are enlarged in the chest or abdomen can present with related symptoms. So for example, shortness of breath or cough for lymph nodes within the chest, or abdominal pain or bloating for lymph nodes within the abdomen. About a third of patients will have what we call B symptoms. So B symptoms most commonly are significant weight loss or drenching night sweats, and somewhat less commonly fevers. About a third of patients will have bulky disease. The definition of bulky disease is somewhat variable, but usually means any lymph node mass that's over 7.5 or 10 centimeters. Quite commonly in diffuse large B-cell lymphoma, we'll see disease outside of lymph nodes. That is called extranodal disease. The most common sites are in the gastrointestinal tract, so for example, the stomach or colon, followed by the skin and bone. This is an example of what diffuse large B-cell lymphoma looks like when it occurs in the skin. Just briefly wanted to touch on something called transformed lymphoma. So when slow-growing lymphoma changes into more fast-growing lymphoma, it's called transformation. Usually, this transformation is to diffuse large B-cell lymphoma. This is pretty common, particularly when patients have lived with indolent lymphoma for many years. Generally, transformation is diagnosed with repeat biopsy, so we can confirm that there's been a change as well as what the change has been too. I'm going to talk briefly about making the diagnosis of diffuse large B-cell lymphoma now. So when we look at lymph nodes, you can see the lymph node on the left this is a normal lymph node with what we call germinal centers, the rounded areas, and quite a heterogeneous looking thing. So it looks kind of different throughout the lymph node. Whereas the one on the right, you can see it looks the same. And so the lymph node has been replaced by the abnormal lymphoma cells. And when we biopsy that lymph node, we see large cells in diffuse large B-cell lymphoma that are often quite diffuse, and that's where the name has come from. These large cells express common B-cell markers such as CD20 and CD19, and we'll talk about the relevance of those two markers later. When the pathologist receives the lymph node, whether it's a whole node or a piece of the lymph node, they look at it under the microscope for an initial impression and then order stains as well as special testing, something called FISH testing, which we'll also talk a bit more about later. And then they put together the features of all of the special tests to make the final diagnosis. This slide shows a little bit closer up picture of those large cells in A and a very close up picture in B, as well as some of the special stains that are often used in diffuse large B-cell lymphoma. When we think about the biology of diffuse large B-cell lymphoma, we've actually learned a lot over the last few decades. Initially, there was a very important study done that described at least 3 distinct subtypes using gene expression. When we separate diffuse large B-cell lymphomas into these 3 specific genetic subtypes, this can help us predict for their outcomes. And activated B-cell type is one of the types that we will be able to identify that has a higher risk of relapse or refractory disease. This is just this shows the different genes that were expressed. And so by learning about how we can group these lymphomas together based on the different genes being present, that helps us to do research to target specific genes and understand why these different types of DLBCL behave differently. This is a list of all of the current subtypes of diffuse large B-cell lymphoma described in the WHO book, which is sort of the ultimate reference for classification of lymphomas. Many of them are uncommon. I've highlighted in purple the ones that we see signed out most commonly. So diffuse large B-cell lymphoma, NOS, or breaking down by cell of origin, which is done using stains that helps to predict those different genetic subtypes we just discussed in the prior slide. So the two main types are germinal center subtype or activated B-cell type. I've also highlighted primary mediastinal large cell lymphoma, which is a fairly distinct subtype of diffuse large B-cell lymphoma. I'm just going to briefly talk a little bit more about primary mediastinal lymphoma. It's generally considered separately from DLBCL overall, although when patients are diagnosed under the microscope, it can look very similar to any other DLBCL. This is one type of lymphoma that's slightly more common in females and tends to occur in a younger age group. It has a very specific way that it presents, so within the mediastinum, which means within the chest, with very bulky and often invasive disease. And usually the lymphoma is mostly above the diaphragm. It's very curable with our current therapies, but is treated slightly differently than DLBCL overall. With respect to the biology of diffuse large B-cell lymphoma, there's a few important things that are incorporated into our treatment algorithms and are important for prognosticating or determining what a patient's outcome might be. So I just want to briefly explain what those things are. So aside from the cell of origin subtypes that we just talked about, another thing we look at is these specific oncogenes, one called MYC, and this is an oncogene that promotes cell growth as well as proliferation, meaning making copies of itself. It's also an important oncogene that can lead to resistance to chemotherapy. There's two ways that we look for MYC. One is by using a special test called FISH, which is where we're probing for a specific translocation, meaning two parts of two genes coming together that normally are not together. The other way we look for MYC is if the protein is overexpressed in the tissue of the lymphoma. That is a little bit more common than seeing the FISH positive because there's multiple ways the protein can be overexpressed. BCL2 is another oncogene. This one regulates cell death. So apoptosis is just a fancy word for cell death, and it's fairly commonly overexpressed. The issue with these two is when they come together. So if they come together with tissue stains positive, then that is something that we know is prognostic. Patients do not do as well, although not to a degree that we modify initial therapy, and they are still included as a diffuse large B-cell lymphoma. Whereas if these things are both positive on FISH, we call that double hit lymphoma, and this is no longer classified as DLBCL, has been given its own classification called a high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 because it needs to be treated more aggressively. Going to move on to staging, and then we'll come back to talking about some of those biology features when we talk about the treatment of DLBCL. So staging is necessary to determine the extent of disease, and that helps guide our treatment plan. It also serves as a baseline to evaluate response. Not everyone needs the same staging, so that's true depending on different types of lymphoma. But also, even within diffuse large B-cell lymphoma, not everyone needs the same staging. Partially depends on symptoms as well as goals of therapy. Generally speaking, almost everyone gets staging CT scans that include the neck, chest, abdomen, and pelvis, and most people would also get a PET scan at baseline. What's a little bit more variable is whether or not people require a bone marrow biopsy or evaluation to ensure that the lymphoma is not in the brain or the fluid around the brain with an MRI or lumbar puncture. So this sort of lays out how we evaluate those staging tests to come up with what stage the patient has. Keep in mind, as I said before, most patients with DLBCL have stage 3 or 4 disease. And so having a single lymph node group or structure or multiple on one side of the diaphragm is much less common. Most patients have lymph nodes on both sides of the diaphragm, so both in the chest and abdomen, or the neck, chest, and abdomen, or people have lymphadenopathy as well as extranodal disease, so outside of lymph nodes, and are stage 4. This illustrates in picture format the stage. So PET scans are going to be discussed in this talk a little bit, with both when we discuss staging as well as response to therapy. And so what is a PET scan? It is a special scan that combines both a picture of the patient's body as well as function by tracking deposition of radiolabeled glucose. It's actually superior to CT scan, both in terms of accuracy and detecting small amounts of lymphoma, particularly for certain extranodal sites, like in the gastrointestinal tract or in bones. When we use a PET scan, it will upstage people sometimes, meaning that CT scan may look to be stage 3, but we do a PET and realize that the disease is actually stage 4. When we use PET scan at the end of therapy, we know it's very reliable if it's negative. However, it's somewhat less reliable and requires some expertise and interpretation when there's positivity at the end of therapy. Small amounts of uptake could be ongoing lymphoma, but they could also be infection or inflammation, sometimes inflammation just from the tumor responding to therapy. Treatment decisions need to take into consideration the baseline PET scan as well as the overall clinical picture, and the physician may determine that repeat imaging or biopsy is needed to determine the best next steps. Bone marrow involvement is actually fairly uncommon in diffuse large B-cell lymphoma. PET can be used to determine marrow involvement. It's actually very good at picking up small amounts of marrow involvement. And for that reason, a bone marrow biopsy is often not required anymore for routine staging. However, you may still need a bone marrow test if you have abnormal blood counts, you're unable to have a PET scan as a baseline for staging, or if you're on a clinical trial. This is an example of what a PET scan looks like. And in this patient, you can see in the neck, there is abnormal uptake, as well as throughout the spine. And so it's showing bony involvement in the femur and in the pelvis. And this patient had a bone marrow test that confirmed that they had lymphoma in their marrow. part of our goal when we're initially evaluating the patient and doing all the investigations to get stage, as well as determine patients' fitness to therapy, is to come up with a prediction, if we can, of what their outcome with our standard therapy may be. And one of the most common ways to do this is something called the International Prognostic Index, or IPI. We use a combination of 5 fairly easily obtainable clinical factors listed there to determine if patients have a very good risk lymphoma, meaning that they're very likely to go into remission and stay in remission, or a good risk, which sort of has a medium chance, but still very good at 79% 4 years post-treatment of going into and staying in remission, or a poor risk. What's one thing that's important to note is that these outcomes are determined in patients who receive full dose standard chemotherapy. And so patients who are unable to receive full dose standard chemotherapy would not be expected to have as good of outcomes. I'm going to move on to talking more about treatment now in this next segment. So chemotherapy. So this is a backbone of treatments of many cancers. The way chemotherapy works is by damaging DNA in the cancer cells, leading to cell death. Generally speaking, chemotherapy works in all parts of the body, although it doesn't always penetrate into the brain. It broadly affects all growing cells, and that's why we can see many side effects of chemotherapy, with the most important side effect that we see as we increase chemotherapy dose often being influence on the normal blood cells, which can result in complications, most commonly infection. Monoclonal antibodies are a treatment that is developed using antibodies to attack cancer cells. And specifically, these antibodies are directed at targets on the cancer cells. So in the case of diffuse large B-cell lymphoma, the most common example is when we target CD20, which is a marker on all B-cell malignancies, or almost all B-cell malignancies. And that is incorporated into therapy to increase response to chemotherapy. There are several other examples of monoclonal antibodies as well, ones that work against B cells, so obinutuzumab, and less frequently in diffuse large B-cell lymphoma in current clinical practice, ones that have other targets. In terms of treatment, if patients have limited stage disease, which is, as we discussed, not that common, generally they can have a more abbreviated treatment course with either 3 or 4 cycles of R-CHOP. If only 3 cycles are given, we usually give radiation to the site of involvement. If our goal is to avoid radiation, we generally would either get a PET scan after 3 cycles to ensure that the disease has responded well and complete the treatment with 1 last cycle of chemotherapy, or sometimes very low risk patients can have a treatment course set as 4 cycles of chemotherapy at the onset without requiring that PET to determine if it's appropriate. Advanced stage DLBCL is much more common, and so most patients will have a course set for 6 cycles of R-CHOP chemotherapy, with radiation added only if there's residual uptake on PET scan that is localized, so not as a rule at the end of therapy. This is an illustration from the fairly recently finalized Lymphoma Canada Diffuse Large B-cell Lymphoma National Guidelines. It walks practitioners through the initial therapy of diffuse large B-cell lymphoma. It highlights a few things. So one is that all patients should be tested with FISH for MYC, and then walks you through that if that is positive, they should have testing for BCL2 and BCL6 by FISH. If that is also positive, then that is not diffuse large B-cell lymphoma. That is that other entity that we of high-grade lymphoma with double or triple hit, and those patients should be treated differently because they do not do well with R-CHOP alone. This algorithm has some variability in limited stage disease depending on where the disease is and what local practices involve, if they tend to use PET guidance to direct therapy, or if they tend to, as a routinely, incorporate radiation into limited stage treatment. For advanced stage disease, after 6 cycles of R-CHOP, patients would be determined if they're in a complete remission. If they are, they're completed their therapy. If not, they would either be assessed for possible radiation or further treatment. So what is R-CHOP? So this is a breakdown of what I mean when I refer to this treatment. The first component is the anti-CD20 monoclonal antibody that is often referred to as Rituximab, although currently within Canada, we use similar drugs with different names, as well as subcutaneous Rituximab after the first dose is given intravenously. The next 3 drugs in the CHOP are cyclophosphamide, doxorubicin, and vincristine. These are all given in the IV. And the last drug, prednisone, are pills that are given daily for 5 days at home. The rituximab and cyclophosphamide, doxorubicin, and vincristine are all given on day 1 of 3-week cycles, with a total of 6 cycles administered. So how do we get this current standard of therapy? Because R-CHOP really is what is used off of clinical trial throughout the world and has been for some time. Well, there's been multiple trials, and the goal of those trials have always been to try to see if we can improve outcomes, so improve the number of people who respond and stay in remission. One of those trials is pictured here. So this was done a long time ago with the concept that maybe if we just intensify the chemotherapy and give more drugs, stronger drugs, higher doses, we'll do better. But unfortunately, this trial did not show a benefit of more intensive regimens compared to that CHOP backbone. We did, however, find that adding rituximab, so adding an anti-CD20, significantly improved response rate and survival by as much as 30%. Other completed studies looking at things like infusional treatment, so using that dose-adjusted EPOCH treatment and using double hit. What if we just give it to everybody with diffuse large B-cell lymphoma? That, unfortunately, did not appear to improve outcomes overall. What if we add other new drugs, change the chemotherapy schedule to give it more frequently? All of these things, unfortunately, to date have not shown a significant benefit. There is a trial that was recently completed called a Polaric study, where a new monoclonal antibody that has a drug attached to it called polatuzumab vedotin that also targets a marker on the cell surface of B cells, but a different one called CD79B is added to the R-CHOP backbone. That clinical trial has not been fully published or analyzed yet, but there's a press release stating that it appears to improve outcome, and that will be presented at upcoming meetings and have further analysis done so we can determine if this is something that might change our frontline treatment going forward. Briefly, just want to talk about how we assess response to treatment. So response evaluation is generally done 1 month post-treatment completion. Sometimes physicians will also restage or reevaluate mid-treatment with either CT scan or PET scan. At the end of therapy, PET scan is the most accurate way to determine response. And this is one of the reasons we want a baseline pre-treatment, is to be able to compare the two. People who do not have complete remission, this is often referred to as refractory disease, so it has not gone into a complete remission. If complete remission is obtained, but then later the lymphoma is confirmed to come back, this is called relapse. This table goes over the different types of response and how they're defined. So complete remission is no uptake on PET scan. There is a standardized way that the radiologists score the PET scan, and anything between a score of 1 and 3 is considered to be a complete metabolic response. When we're using CT scan to determine if there's complete remission, it relies on determining if the size of the nodes or nodal masses have all decreased back to normal. Partial remission is if there's an improvement compared to baseline, but still residual uptake. On PET scan or on CT, at least 50% regression of the lymphoma, but not all resolved. Stable disease is improvement, but not quite partial remission. And progressive disease is new disease or progressive uptake on a PET scan, or progression of existing nodal masses or new growth of nodes or masses after initial response on CT. And so just to summarize, our initial therapy is R-CHOP. The number of cycles depends on whether you have limited or advanced stage disease, and radiation may be added depending on response to therapy. We're going to move on to talking a little bit more about relapsed refractory disease. Unfortunately, there is a significant portion of patients that will either relapse or have refractory disease to initial therapy. Identifying the patients who are likely to relapse or have refractory disease is one important step in determining how to best tackle this problem. Ways that we can do this are with traditional clinical risk models, so the IPI, using molecular subtype and genetic features that are given to us in the pathology report, as well as potentially early response with PET scan. The more challenging problem is knowing what to do when we identify patients we think are likely to have relapse or refractory disease, and figuring out how to modify therapy to overcome these negative features. Response adaptive therapy is something that is used most commonly in Hodgkin's lymphoma and really hasn't been incorporated into care routinely for diffuse large B-cell lymphoma. We do know that early PET scan, so early response on a PET scan, is very predictive of outcome, and it's even better than IPI, predicting who will do well and who may not. The idea of using response adaptive therapy is taking that early PET scan and making a modification, whether it be additional therapy if the PET remains abnormal, or abbreviating therapy if it's normal or negative. But as I said, we have not The studies that have been done to date have not shown that we can successfully modify therapy to improve the outcomes, unfortunately. This is a schema of treatment suggestions for relapse or refractory diffuse large B-cell lymphoma. A lot of it hinges on whether a patient is fit for intensive therapy. And unfortunately, when we look at the literature, we see that about half of patients aren't, partly because this is a population of patients that can be quite elderly with other medical problems. The lymphoma itself makes people very sick, and also our treatments for relapse are pretty intense. So it's that combination of things that is one of our challenges, that to start off with, many people are not fit for intensive therapy. And so if we follow this diagram, patients who are not fit for intensive therapy, their management is really not with the intention of cure. The management is to improve the symptoms and hopefully prolong life. And so that management is often referred to as palliative. There's lots of options for palliative therapy because nothing is really stands out as being the best option. Although I'll talk at the end about a new therapy that appears to be a really good option compared to a less commonly used one. Patients that are fit for intensive care therapy, our goal is to see if we can get them to an autologous stem cell transplant. And so if they're eligible for an autologous stem cell transplant, we give further chemotherapy, most commonly a regimen called RGDP, and then assess response. Patients that are responding to RGDP often will move forward with autologous stem cell transplant. Now the challenge here is many patients with relapsed or refractory lymphoma will not respond to that second-line therapy and therefore not be eligible for autologous stem cell transplant. Those patients potentially could be eligible for CAR T therapy, which we'll discuss briefly. If they're not, then again, it's palliation or clinical trial. So just wanted to talk briefly about autologous stem cell transplant. The idea of this is that chemotherapy, as you heard earlier, kills cancer cells. And sometimes when cancer cells are not responding to chemotherapy, one way to overcome that is just to give more, give a very high dose. So the more we give, the more we can kill the cancer cells. However, chemotherapy has a lot of side effects, and as we increase the dose, the life-threatening side effects become increasingly problematic. So an autologous stem cell transplant or autologous BMT is a shortcut around this side effect of chemotherapy of increasing toxicity and increasing low blood counts. The idea is that we collect your own stem cells, which are kind of like the factory cells in your bone marrow, and put them in the freezer. Then we give you very high dose of chemotherapy. That would not be practical without having those stem cells to give you back. So instead of neutropenia or low white blood cell count lasting 4 months, blood counts can recover in around 2 weeks because we've given you back those stem cells or those factory cells. And so the goal of autologous transplant is to deliver higher than normal doses of chemotherapy in a safe way. The recommendations of who should receive autologous stem cell transplant are listed here. And so people have to be relatively fit. You know, what does that mean? That means no major organ problems, so no major heart problems, no major liver problems. Their disease has to be responding to second-line therapy. That is often one of the biggest barriers in people that are otherwise eligible for transplant. People need to have a fairly good performance status, meaning they need to be up and about for most of the day and able to perform their own self-care. The reason for that is if you're not able to, we know that complication rate is very high, and that is prohibitive for giving this treatment because it's quite toxic. There cannot be active central nervous system disease to proceed with an autologous stem cell transplant. As stated earlier, people have to have adequate organ function to proceed. Okay, so going back to the algorithm, so if people are found to be eligible for transplant, they get second-line therapy, which is most commonly R-GDP, sometimes can include these other regimens here. If they respond, then they proceed with the autologous stem cell transplant. Unfortunately, even then, about half of people will relapse post-transplant, and then they're faced with, again, the decision to use palliative therapy or clinical trial, or whether or not they're eligible for CAR T therapy. So we'll talk more about CAR T therapy now. So what is CAR T cell therapy? So this is chimeric antigen receptor T cells. So T cells are a type of lymphocyte in your body or white blood cell in your body that are genetically engineered to express an antibody. In diffuse large B-cell lymphoma, we engineer T cells to express a B-cell antibody called CD19, and then use that to get your own T cells to attack your lymphoma. Health Canada does have several approved indications for CAR T cell immunotherapy. One is in acute lymphoblastic leukemia in pediatrics and young adults, and the second is in adults with large B-cell lymphoma that have relapsed or have refractory disease after 2 or more lines of systemic therapy. This illustrates the procedure for CAR T cell therapy, which is not too different in some ways from an autologous transplant. The main difference being that when we are doing the apheresis procedure, we're selecting for T cells rather than stem cells. And then those T cells have to be specially manufactured to have the CAR product inserted so that they will then be able to attack your B cells. And so there's a lot of quality checks and logistics that goes on between taking out the T cells and infusing them, unlike with an auto transplant where we sort of just take the stem cells, make sure there's a good number of them, and then freeze them. There are a lot of challenges, honestly, with CAR T therapy. So CAR T therapy is something that is an amazing breakthrough, because people who previously relapsed after an auto transplant or did not respond well enough to therapy to get an auto transplant had very poor outcomes with a very short survival time. And CAR T therapy can achieve a remission and response in a portion of those people. But the challenges are really access. So this is very specialized, and you need not only a specialized team, but a specialized lab to be able to harvest and process the CAR T cells. The processing time does take time, and people are often very sick at relapse, which is a problem, partly because of the time needed to get prepared, but also because at present, there's really only 4 provinces in Canada where CAR T-cell therapy is administered, meaning that many patients will have to travel far from home to receive CAR T-cell therapy. Another challenge is the cost. So the product of the CAR T-cells itself is approximately $500,000, with the additional costs of the potential hospitalization, all the follow-up care, the drugs needed, etc., increasing that cost even further. So I'm just going to summarize some of the newer treatments for diffuse large B-cell lymphoma before we complete the presentation. And so one of the challenges that we talked about is that often the treatment at time of relapse is very toxic, and that options for people who are not eligible for intensive therapy are largely palliative, meaning improved symptoms only. There was a trial done using Positron, which is that monoclonal that attacks the B cell by a CD79B and has a drug attached to it, so it actually delivers the drug directly into the B cell, with bendamustine, which is a chemotherapy drug used in lymphomas, more commonly slow-growing lymphomas, and rituximab, compared to just giving bendamustine and rituximab, which is not a commonly used combination for relapsed diffuse large B-cell lymphoma, but is a reasonable comparison. And so when we did this study, we found that the overall survival was actually significantly better in the group that received polatuzumab. And so this was a first that we showed that we can improve survival time. This is not a cure, unfortunately, but it seems to significantly extend survival. And so this was recently reviewed by the Pan-Canadian Oncology Drug Review process with a positive recommendation nationally, but that still has to be reviewed by each province with funding decisions and implementation. And so it's not something that is widely accessible to patients yet within Canada, but hopefully will be soon. CAR T-cell therapy with the 2 main products listed is available in Quebec, Ontario, Alberta, and BC at large centers. Other provinces need to send patients out, so whether it be to one of those provinces listed or sometimes out of country. And so CAR T therapy is available, but there is significant access issues currently. CAR T-cell therapy is being studied to be used earlier on rather than waiting till a third treatment. Bispecific antibodies, or a special type of antibodies that bring together, that target 2 different markers on cells at the same time. These have been very promising looking in early clinical trials in diffuse large B-cell lymphoma, and I think they're a treatment that we'll be seeing more of in the years to come. Tafasitamab is an anti-CD19, which is another marker on B cells that has been combined with a drug called lenalidomide that does show some activity in relapsed diffuse large B-cell lymphoma. This has been approved by Health Canada, but not yet gone through the Pan-Canadian Oncology Drug Review process, therefore not widely available or funded. To summarize, diffuse large B-cell lymphoma has no one presentation. It can be very limited stage to very advanced, and can occur in people of all age spectrums. Most patients are cured. However, as you heard, the challenge really is for patients who relapse or have refractory disease. A combination of clinical and biological features, as well as PET-based response, predicts patients that may have a poor outcome. And our challenge is how to improve those outcomes. So one way to do that is clinical trials of new initial therapies. I would encourage anyone who's newly diagnosed to consider asking your physician if there's any new initial therapy trials open. That is how we learn about improvements, and we get access to new treatments for patients. We need more responsiveness to treatment at time of relapse, because one of the limiting factors in proceeding with an autologous transplant is lack of response to second-line therapy. And that also can be a limiting feature for CAR T if patients just have too much lymphoma and are too sick from it. So we need more responsiveness to treatments, but also less toxic therapy, so more people overall can be eligible for further treatments. Central nervous system relapse is uncommon, but it's devastating when it happens. So we need to be better at predicting, and also we need to be better at preventing that as a relapse site. And I think the future of diffuse large B-cell lymphoma is going to be tailoring treatment based on those genetic features and biology described earlier. So that's all I had today, and I want to thank you very much for your time, and I hope that that improves your understanding of diffuse large B-cell lymphoma.
Thank you very, very much, Dr. Skrabek, for your excellent presentation on DLBCL, and we appreciate your really great overview of this lymphoma subtype, detailing a bit more specific information related to the treatment options that are available to patients in both the frontline and relapsed refractory settings, and also highlighting some of the newer treatment options that we're starting to see across the different provinces. I think a lot of the excellent work on the treatment algorithms that were included within this presentation actually came from the Lymphoma Canada clinical committee that we had worked together with specialists from across the country to develop guidelines for both the frontline and relapsed refractory setting. And Dr. Skrabek was involved in that, so thank you so much for that as well. I would now like to go ahead and direct our audience to please attend the breakout session on non-Hodgkin lymphoma to have your questions answered by a live panel of hematologists and medical oncologists. Once again, thank you so much, Dr. Skrabek, and thank you as well to our live audience that attended. Thank you.